responders. So that's the topic for the day. Very important topic, pertinent topic for the day, and I think we have to learn it well. Ribri Barita. So what is happening is that are adjuvants important for us? What are adjuvants? Are we giving them properly or not? Sometimes in our Josh, we are overusing them, and then we are all going in a different direction. So adjuvants can be good, they can be harmful. So let us see, and they can be a little bit expensive also. So we have to see which is good, which is bad for us. So all of you who is, hi Shivani, how are you? Shivani from Gorakhpur. So, so all of you will
Fine,
have
fine,
to.
sir.
Yeah, hello, how are you doing, Shivani? Good. So
Fine, I'm doing fine.
good, good, good. So we have to just, we have to know that in case, see, we're going to give you some very good literature after the classes, as I always do,
So your
to save my number.
voice is cracking.
My voice is cracking. Is my voice cracking? Everyone?
No, sir. No, sir.
No, it's fine, sir.
It's fine. Fine.
Recording in progress.
Sauji. A lovely guy, lovely guy. I fell in love with him, and he was always full of smiles and happiness. So, Sauji, Umesh, are you there?
Yes, sir. Yes, sir. Good evening, sir.
Umesh,
Good
good to see
evening.
you, Umesh. And this is about Umesh, and he's worked so much, and he's a dermatologist, cosmetologist, uh, an IVF specialist, and an embryologist, all combined into one. He's got a very, very big cosmetology center in his town, and I think he has already resigned from his job also after meeting me.
Yes, sir.
So,
Yeah.
so over to you, Umesh, and we'd like to hear from you. And good to see you back.
After your wise advice. Good evening, all of you. Good evening, all my colleagues, sir. क्या बोलूं सर, आई एम वेरी डिलाइटेड जब फोन आया कि आपको गेस्ट ऑफ ऑनर करना है, मैंने बोला कि मैं कर सकता हूँ या नहीं कर सकता हूँ, आई एम दैट, मतलब उतना एबल हो या नहीं हो, पर
That's my topic for the day today, and that's my number. Please save my number, written over here, and given in every slide below also, to get very nice world-class articles. Today we talk about something called adjuvants. Adjuvants क्या होता है? Adjuvants can be a therapy. So look at what adjuvant is. It can be a therapy. It can be a diagnostic test. It can be a treatment. Any of three things, which can help us improve our outcome. And adjuvants are not only in medicine, it applies to wherever we go. So we have adjuvants to grow our embryos better. Some people add HCG, some people add GCSF, some people add albumin to the medias and make medias richer. Some of them can make our embryos grow better. Some people carry out biopsies. Some people give calcium ionophores. And we want to have a nice, good pregnancy coming up. That's the aim of using an adjuvant. Help us in getting proper, better implantation. The whole, what is here on the screen is a pretty complex thing. Actually, I never understand these things. It's so difficult to understand. But as we are evolving, we are having a peep inside what all happens at the level of microvilli. We're trying to find out. And we're trying to correct those factors which are leading to some sort of diastasis causing the problems. And then there are so many pathways, integrant pathway, IGF pathway, stress response. All these pathways we are trying to correct now. We're using different types of drugs or therapies. We talk about LAF, we put multiple receptors, so we are trying to correct them, looking at Notch2 pathways, VGF pathways, but I won't talk about them in detail. Neither I know also. I can accept that these things are pretty messed up and beyond my comprehension. Coming to the adjuvants, what are adjuvants? Backgrounder is that adjuvants are an ingredient. It can be a drug or a method that enhances the effectiveness of medical treatment. So anything which can help us, even you know, talking to somebody and holding their hand and saying hello to them with love, tender loving care is an adjuvant. Acupuncture is an adjuvant. Meditation is an adjuvant. So they are different sort of therapy that talk about them later. But just know that adjuvant is also called adjunct and is also called add-on therapy. ये तीनों चीजों को याद रख लीजिएगा कि adjuvant is adjunct or add-on therapy, and it can be an agent, tool, or a procedure. It can be an agent, tool, or a procedure. It can be doing an endometrial biopsy for an ERA, can be an adjuvant. Maybe doing a pap smear can also be an adjuvant in case we don't do it properly. A large number of babies are taking birth, but we still have a low birth rate. But that I won't go into today. I'll say that we want to improve. So we want to give something to our patients, which we call as add-ons. Add-on. They're called adjuvants because we want to improve the pregnancy rate because we are getting stuck at 30% live birth rate. When you get a failure, we want to do something. We want to improve our outcome. And then sometimes we go overboard. Sometimes we control what we are doing. But to meet the hopes of a patient, we want to use many technologies which are actually not right. And a lot of world disputes are there that we are spending too much of money on molecules like DHEA, CoQ10s, melatonin. So I want to ask any one of you present here, is there any one of you, how many of you are using DHEA in your practice? Just a few hands up. Okay, a few hands up. Anuradha, I can see, I've seen your hand. Few hands up. How many of you use something like CoQs? I use them like water. All hands up. All hands up. Melatonin is normally coming along with DHEAs. We all use melatonin quite a lot. A large number of, hi Sureka madam, I see your hand. A lot of people are using something in the medias, culture medias, to make medias better. I can see Anju's hand going up. So these are few things we are doing nowadays for better outcome, for having a better outcome. One sec. I think it's got here. And some use time-lapse therapies. So there are many things which people are doing to have a better outcome. So when I wanted to research for you, every year things change. I had taken a similar talk around 1.5 years back, but things have become totally different. They are changing. So I'm repeating the talk again. Now we are at 300 plus number. So when I look at the whole articles review which I've done, review of literature, I'm like this. I use large number of therapies, but I'm confused. And I'm going to also confuse you like I'm confused. ASHRAE, HFEA, they do talk about that we are trapping patients like this by giving them unwanted things. What is good, what is bad is actually our own inner call. But I'll tell you what is right, what is wrong as per the literature review. That'll be my job for the day today. In next 30 minutes, I'll talk about it. And then I will also invite our embryologist, my backbone, Dr. Yogesh Kumar. I'll call him also to sum it up. So we have few daily practice points, day-to-day application, simple to perform. Why are we talking about adjuvants? What is the need actually? So we have to understand our perspective. So we want to do something more for the patient. But remember that whatever we do should be reproducible, auditable. We need to treat, but do no harm. And in case there's a research element in it, then call it a research element. Do it for research. Don't apply to everyone coming to you, hoping that you'll do some wonders. That's our perspective. Looking at the patient's perspective, what do they want? They want hand-holding, counseling, and they ask anything else. क्या करें? इसके ऊपर क्या करें? And so we start advising many therapies which are not good for the patients. There's a buzz in the market that we are overusing in a hurried manner new technologies. And they are quite ineffective, and in some cases even harmful for the patient. So let's see how they work. We use large amount of antioxidants, large amount of therapies, and we are hoping that the patients will become better. Right, I agree with it. But here, read this. I've written here very clearly that many things which we carry out, they are at nascent stages of development, lack clear clinical evidence or safety, and are expensive. So patient expectations and market forces and online information is driving us to use a lot of add-ons. What I won't speak is about my own perspective, but I use a lot of add-ons. I'm writing it, I use a lot of add-ons, hoping something will happen, but I draw my limits too. But I do use. I won't talk about dosages and technologies per se. Let's look at it, what the guidelines tell us. Gentlemen, ladies, I start my talk here and we're at around 315 number, and I'll draw my strength from three different resources. One is called David Gardner, Volume 2. So in case any one of you who doesn't have this book, I think we have given to all. Volume 2, all of you have it already with us. Read page number 622. It starts. It's a 5-page, 7-page article. Page number 622, read David Gardner. That's what I'm going to tell you here. There's a misprint there also, I found out. There's a misprint, major misprint there. Try to find out what is the major misprint. I'll wait for your answer. I'll refer to Cochrane reviews and ASHRAE guidelines, which is very recent. What are different type of adjuvants? We use DHEA. We use 1% androgens. We use growth hormone, metformin, antioxidants. Some people use empirical estrogens when it becomes adjuvant, aspirin, heparin. We use sildenafil, L-arginine, uterine relaxant like piroxicam, rocibam. Endometrial scratching many people carry out. Some advise yoga and meditation. Some people use time-lapse imaging. Some use embryo glue. Some do assisted hatching. And some freeze for all, like I also do. Freeze for all in many cases. Some people carry out artificial oocyte activation. We call it AOA. Some people do PGT for anyone more than 38 years of age. Some people do autologous endometrial co-culture media injections. Some do DNA fragmentation indices, antioxidants empirically in large number. Some people carry out IMSI, some carry out ICSI. Some people carry out sperm activation by petoxyphylline and theophylline. Some carry out magnetic sperm sorting. Some use heated centrifuge machines. Some carry out microtissa, hoping for a better sperm outcome. Some use microfluidics. Again, some people do intralipids, some people inject GCSF, some carry out hysteroscopies, some inject HCG in the uterus, autologous PRP, intrauterine HCG administration, stem cell therapies, steroids, IVIG, TNF agents. Anything I have missed? Any one of you? I've taken you through whatever I could scratch out from the various books, the antioxidants. Yes, I've not spoken about something like grapes, which are very good antioxidants. I've not spoken about grapes. I'll talk about it later. But all the drugs, technologies, whichever I could get, I've written for you. Anyone can find anything missing here? Any one of you?
Amla.
आमला भी आएगा हिंट के अंदर आएगा स्ट्रॉबेरीज भी आएंगी, सब आएगा।
LIT सर, LIT।
NSFIL16 sir.
LIT, LIT मैंने लिखा है, LIT, LIT is a very important thing. So LIT is also there. I'll be covering LIT. Thank you, sir.
Sir, L-arginine and sildenafil.
लिखा मैंने, लिखा 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 जो नहीं लिखा
N-acetylcysteine sir. NAC.
हाँ, yeah, no, so many drugs are there, madam. So beautifully you're bringing out. So I'm happy that you're getting involved.
Sir,
So we put some
prebiotics and
Vaginal
probiotics.
probiotics. Vaginal
antibiotics.
Probiotics.
Very good,
Vaginal
very good.
probiotics.
Yeah, probiotics, antibiotics. Very right, Reena. I was wondering where have you disappeared. I was missing you, Reena, for a long time. I'm not seeing you. Good to see you. Good to have you back.
Thank you, sir. Thank you.
Good.
HCQ sir.
Huh?
Immunosuppressors. sir.
HCQ.
Immunosuppressant HCQs. Very good, Arvind. Very good.
Steroids.
Melatonin, sir. Vitamin E.
Vitamin E, selenium, vitamin C, zinc,
Folic acid.
magnesium,
Zinc,
folic acid.
Folic acid.
Yes.
Melatonin, sir.
Good.
Nowadays sir, leucine has been added.
Leucine for neonates, prenatal or
Taurine.
early natal.
Also
Good.
for anti-obese drug.
कौन सी होती है? Which one do you give?
एंटी-ओबेस ड्रग सर बहुत जरूरी होती है, इसलिए मैंने उसको ग्रुप भी बता दिया।
अच्छा, मुझे
Sir,
पता ही नहीं, मेरे को भी
Bizepta. Now it has been introduced by Zepta.
मेरे को लेनी चाहिए अपने लिए पहले तो. I should take it for myself only. Okay, great. So जो पहला वाला इशू जो मैं पकड़ रहा हूँ, वो पकड़ रहा हूँ मैं POR का. I'm catching up the issue of premature poor ovarian response. पहला इशू मैंने उठाया आज, पहला इशू उठाता हूँ. और इस इशू को अगर मैं आगे देखता हूँ तो कहाँ चला गया? Yes. When you look at this issue, it's like a woman looking at her eggs, and after 40 or 38, the eggs they start aging. They start aging. And definitely, yes, timer is on. Here I've taken the references from the Gardner's book. A nice article, chapter, page number 622. All of you must read this. Must read this. So we have some strategies to improve ART outcomes for poor responders. हम क्या कर सकते हैं? We can increase the number of follicles in case we can do that. But वो होता नहीं है. It can't be done. So in the cycle, we can increase recruitable follicles. Before, we cannot increase, but we can recruit more. Yes, this is possible. And improve oocyte quality, this is possible. So whole battle is about in POR is to increase our recruitable follicles and improve oocyte quality and try to get our FORT and FOI the right order. The first drug which comes to our mind is testosterone. It is a 1% gel, normally given between 10 to 12 milligrams a day. This is from the same chapter. They say that testosterone, use of testosterone before ovarian stimulation is probably not recommended for poor responders. Probably not. But this is a forest plot. Just see that this for clinical pregnancy rate and this for the live birth rate. You find that it favors testosterone. This is one. The diamond favors testosterone. So it is, I think we can give it a try. Coming to live birth rate again, you'll find a diamond is not touching the null line. It is away from null line, away from 1. And you see the relative risk is 2.09, which is positive. And this confidence interval is not touching 1. It is above 1 and not touching the null line. It means that it is not a bad drug. But they've said that we should do more studies. I agree. But testosterone is one drug which I think can be tried. I'm also using it. But I think we need more research. DHE. So whenever you look at a forest plot, these are the various studies which are there. Multiple studies are there. This year in which they have done, and these are sample size. When we draw on the null line, we find that the diamond is touching the null line. When diamond touches there, this means that it is ineffective because confidence limits are covering 1. That's the way we read a forest plot. And so here it is a clinical pregnancy and this is a live birth rate. So you can find that DHA is touching 1. When any drug ka diamond touches 1, it means that it is ineffective. So not recommended for poor responders, but I also use it quite a lot. Third drug, which they talk about, is using growth hormone. And growth hormone again, I think there's a misprint here in the book itself. So it is not recommended for poor responders. Growth hormone is just, look at this, it is
Yeah.
borderline and a diamond is very near. But growth hormone can be tried. I'm also trying it. But as per this, it is not recommended for poor responders as per Book of Gardner. Coming to antioxidants.
నువ్వు నాకు చూపించాల్సిన అవసరం
నీకు నెక్స్ట్ ఎప్పుడైనా అవసరం అయితే తెలుసు.
Our antioxidants are we are giving it for as when we have reactive was the oxygen species and we want to fight the free radicals, we give antioxidants. And then in endometriosis, PCODs, hydrosalpinx, male factor, we find that obesity, alcohol, antioxidants are high. PCOD have got oxidative stress, and same with the different types of endometriosis wherever they are present, they can lead to oxidative stress also. So what we give is CoQ10, melatonin, and L-arginine. And all the drugs are, we are all using them and they all work pretty well, I feel. But when you look at review the world literature, they are basically all acting at the level of mitochondria, like CoQs, and giving it more energy. And look at the outcome from the textbook of Gardner. It's written that none of these interventions has the evidence to recommend for a routine clinical practice. This is what they have written over here. So not recommended. Coming to the Cochrane. So it means that we are not giving any sort of antioxidants to any patient. They don't work. Something you take with a pinch of salt because we are all using it, but that's what books have written. Coming to Cochrane library. Antioxidant for male subfertility. And look at this very crowded slide. I understand that. But they say that the overall, it is not recommended. They say it may work, but we need more studies. So they are not saying that we start using it and there is insufficient evidence to draw conclusions about antioxidant use and risk of miscarriage. So they're on the borderline and they say we need to do more number of studies and large, well-designed, randomized placebo-controlled trials are needed before we talk about giving.
बाद में खेलेंगे बैठो.
We are giving it routinely.
थोड़ा बैठ जाओ.
This is what Cochrane says.
बैठो.
Antioxidant for the female self-fertility. You can read it.
जाके बैठ जाओ.
Low to very low quality.
मिजू माता.
Taking an antioxidant may benefit fertility.
बुला रहे.
So there is limited evidence in support of supplemental antioxidants for fertile women. So what we've learned here is, I've shown you two different literatures. I've shown you textbook of Gardner.
बाद में जा.
In that, as compared to whatever you give, I think the only DHA they have ruled out completely. DHA has got not much of benefit. Testosterone, borderline. I think we can definitely use it. Growth hormone also is diamond is away from the null line, which is the central line. We may use it, but doesn't give much of benefit as per the final answer. Coming to the Cochrane. Cochrane is also borderline and not giving you the final answer. Now coming to the major article, which I'm going to cover for you today. And this is called Good Practices. And this came from Ashray. I am sure you would have seen that. How many of you have read this article? This article came in 2023. How many of you have seen this article? I want to ask you. No one. No one has seen this article? I'm quite surprised. Nobody.
I have gone through, sir. I have gone through. Good evening.
Gone through. Good evening. Good evening. Yogesh, hi. It's called Yogesh. So, everyone, he's Dr. Yogesh. He's our more than an embryologist, his younger brother, and he's a ace embryologist of the country. Yogesh, I'm going to invite you at around 9 for 5-6 minutes.
Thank you, sir, and good
Okay?
evening, everyone. Good evening, everyone. And thank you, sir. Kind words.
Thank you, brother. You reached home, घर पहुंच गया. Good.
हाँ, बस अभी भी पहुंचा, sir. Just
अभी
now.
पहुंचे.
Just now.
Great, great. So, first of all these articles, which I'm talking to you today, will be given to you. So don't sweat about anything. Sare articles will come to mailbox. In case you have not, you are for the first timers with us today, you can always send me an SMS message on my mobile number. And my mobile number is written in every slide down below. It's written over here also. So now what they have done is that they have, speaking about different type of tests, and these different type of adjuvant therapies. They have divided it into diagnostic and diagnostic test adjuvants. Diagnostic test. Then they've got laboratory test and interventions and clinical management. So that's the way they have decided the whole protocols. And let's see how they work. So before we read any guidelines of ASHRAE, we have to know how ASHRAE works. This is a very important part of your learning. Table 1. This will be given to you in the night, so you don't worry about taking many of notes. So they have written, it can be either recommended or not recommended. It can be recommended or not recommended, or it can be considered or currently not recommended for routine clinical use. So जो not recommended hai, they are basically can be done, but in the research settings. They are research settings. Don't advise to the people take proper consent before asking for non-recommended therapies. Research चाहिए. Currently not recommended for routine use can be, these are optional. You may use it, but we need more evidence. With time, we may start using it. We have recommended ones. Yes, you can use recommended ones. That is never a problem. Recommended ones are always good to go. So there are, and then there can be considered. So there are total 42 recommendations. 42 recommendations, which I'll be covering for you. And only 3 are, as I could only trace 3 in recommended ones. Rest all are either not recommended or can be considered. So only 3 are the ones which have got concrete evidence. I'll talk about them. But again, when I go to HFEA guidelines, they will differ. So whenever we have talk about ASHRAE, they have got quality of evidence grades. High means that we got 4 pluses here. And so true effect lies, you can use it. It's a good evidence. Moderate, low, very low. Very low means very little confidence. So we should go for very high evidence, which you hardly ever get. So we are normally at low evidence or a moderate evidence. Now let's see how the magic begins. I'd like to ask you now, how many of you carry out routine hysteroscopy before IVF? A lot of people do. But how many of you do carry out routine hysteroscopy before IVF? Anyone?
Not a
Anuradha.
routine. Yes, sir.
So Anuradha does. Very nice. So हमें बात करना है. I appreciate Anuradha. She says she has raised her finger. Okay.
No, sir.
So Anju does. Anju does. So many people do.
I
Hi
do.
Rupika, how are you?
I'm good,
Rupika,
sir.
तुमको
I'm
याद कर
also
रहा था
good,
मैं.
sir.
Good, good, good. So many people do. Nothing wrong in it. Nothing wrong in it. Many people do it. That's absolutely okay. Lata, PGI, or not PGI, Jipmer.
Sir.
Do you do hysteroscopy for all?
Hysteroscopy, not, I mean, before, sir, IVF as such, you know how, but we do for some patients, not all, because we
Not
do a
all.
3D scan.
3D scan.
If there's a doubt, yeah, but I'm not doing as a routine still, sir.
Routine
We do
still.
hysteroscopy, but not.
So let's look at the guidelines. Now, I'll be covering all. This is the first category, diagnosis. इसमें total number he has taken is 3. 1, 2, and 3 recommendations in diagnosis. So screening hysteroscopy is screening. It's not operative. It is screening hysteroscopy. ERA. lot of people are doing ERA, left, right, and center. कुछ और नहीं तो ERA कर दो. And then there are immunological test and immunology treatment, what Dr. Pachdev brought out some time back. Look at the screening hysteroscopy. It is currently not recommended routinely. Should not be done. Screening can be considered in patients with recurrent implantation failure. So it is never recommended कि तुम हर केस में start doing hysteroscopy. I fully agree. I also don't do until it is operated. And even for implantation failure, it can be considered, as you read here, it can be considered. It is not recommended. Keep it in your mind. ERA, not recommended. So please don't carry out ERA right, left, and center. It's a fashionable thing. Every center, I find large number of centers are just doing ERAs for every patient. Out of one failure, ERA कर दो. दो के बाद ERA कर दो. नहीं करना. Not recommended. Then coming to the test of immunology, a large number of, look at the evidence. The evidence is low, but large number of people do uterine killer cells, another sort of thing, peripheral blood test should not recommended है ये. ये करना ही नहीं है, not recommended है. No rationale for these tests at all. They say that KIR and HLA genotype is not recommended for routine use. So all these immunological tests have got no meaning. They are not for routine use. Immunological treatments, intralipids, IVIG, LIF, PBMC, stem cells are not recommended. In case we do, it's okay, but do it as a research setting. So many people are learning. Don't start doing it for every patient. They are not recommended. Coming to, so there are 3 diagnostic tests and adjuvants. 3. These 3 I've covered for you, and we say that only one is a bit sensible is hysteroscopy when we have got ARIA or even implantation failure. Coming to the laboratory tests now, these are all per the ASHRAE. A large number of you or us, we carry out artificial oocyte activation. It's becoming fashionable. Everyone is doing, large number of people are doing oocyte activation.
You want to read?
It is not recommended. Oocyte activation, not recommended. It is recommended. So here I'm drawing a circle. It is recommended. I'm putting a star here. And I can see Vaishali raising her hand. You can talk, madam. You can unmute and talk. It is recommended for complete activation failure, very low fertilization failure, or globospermia. Otherwise, it is not recommended. This is one recommendation we get here. Out of 3, one recommendation for the previous failures, ICSI failures, low fertilization, globospermia, or very low fertilization, less than 30% fertilization, we can do it, but not as a routine.
थोड़ा बैठो, wait करो.
Mitochondrial 3-parent baby, I think we are not doing it as such. It is not recommended. We need ethical clearance.
Good boy.
In vitro activation of dormant follicles. This again not recommended. Does someone know what is in vitro? What is in vitro activation of dormant follicles? Does anyone know here? What do we do in vitro activation of dormant follicles? Any one of you? So here we take out the part of the ovary, cut in small fragments, put that bit of ovary in certain chemicals, and then we put them back in the body. It is called in vitro. In vitro means outside the body. In vitro activation of the follicles, that is called IVA. We call it IVA, and it is research not recommended. IVM, clinical rescue IVM, many people do, but here again it's very clear that currently not recommended. IVM is not recommended for routine clinical use. So don't do IVM. And nowadays IVM का main indication was PCO patients. But now with the ANTAC protocol coming, we have less amount of ovarian hyperstimulation as such. So IVM doesn't have much of role for PCOS now. Dr. Vrishali, you wanted to say something? You can
what
speak.
is artificial oocyte activation, sir?
इसमें क्या होता है? We use some sort of calcium ionophores. What happens? We understand that for any egg to get activated, it needs calcium. When the sperm enters an egg, that sperm will activate the egg. Sperm has got certain chemicals, PGL2. When it goes inside, it will activate the egg. But what happens in case we are having repeated failures of fertilization? We feel that the calcium oscillations are less in the body. So we carry out an ICSI. ICSI करने के बाद तब egg को we keep it in some media that is called calcium ionophore media. So that calcium will get inside the egg and activate the egg. So that should not be done for all. Should be done for confirmed FERT failures or poor fertilization people. So don't do it for everyone. This is what I want to tell you here. So this is many people are doing as a routine that they keep their eggs in the media for around 10 to 15 minutes and then they keep it in the incubator. That should not be actually done for all. So what we have learned is that we have come to one recommendation here. Is it right, Shani? Have you got the answer?
Yes, sir. Thank you, sir.
Yeah. I covered about this media in the last class on embryo culture medias. I covered it at great length, what it contains, how it works. It's not for a routine application. This is what I want to tell you here.
So I had missed that class actually.
कोई बात नहीं. It's a calcium ionophore.
Okay, sir.
Now coming to another thing. Intervention. We all carry out sperm DNA testings. Is it important or not? Should we do it or not? It is currently not recommended for routine clinical use. So don't do it for all. Until it's indicated, you may do it, but not for all. A large number of us, we use sperm activation. We feel that sperms will become stronger with that. But it is not recommended for routine use. Not recommended. And we only do it for the second recommendation comes positive here, along with AOA. We do it when there is total acinospermia. When we only use it for primary or secondary total acinospermia, otherwise we don't use sperm activation. So when there is complete immobility, only then we use sperm activation. We use PTX, pentoxifylline, or we use theophylline.
Sir, we cannot see your screen.
You can't see my screen?
No, sir.
All of you can't see my screen?
We can see, sir.
We can see.
Only your face is visible.
I'm writing on the screen. Can you see what I'm writing? You
Yes,
see
sir.
that?
Yes, sir.
Yes, sir. We can see.
But it's very
Thank you.
small. It's not
This is
visible.
small. This is small one. I'm sending you the article. See, I have copied from there exactly from the book. These articles will get by tomorrow morning. I'm just bringing your attention towards. I have copied from the book directly so that you're able to understand things better. Just remember that artificial oocyte activation is not recommended till the time we have got previous FERT failures or globospermia, and artificial sperm activation should only be done for complete acinospermia. So there are two recommendations come positive till now. So many people use something like hyaluronic acid binding assay and PIXIES. Now these are not recommended for clinical use. So PIXI is not the right thing. It should not be used and currently not recommended for routine use. So PIXI is not recommended. In case you want to use it, it's out of the routine. You may use it, but it's not recommended for a routine use. Magnetic sperm separation, not recommended. These are few guidelines which are very clear guidelines from FDA. Microfluidics can be considered. Can be considered. This means it comes in the category 2. In case you remember, I've showed you this. Look at this now. We had recommended ones. We had can be considered ones. We have currently not recommended for routine use, but later on, optionally we can apply it. An option means that we can apply anywhere we want to. And not recommended means not to be done until we have research going on. So when we come here, so Pixie, it is not recommended for routine use. And when we come to the microfluidics, it can be considered. This is good. It is category 2. We can use microfluidics, can be considered. And coming to IMSI, again, not recommended. Later on, probably it may come, but presently not recommended. Now coming to people using interventions like adding growth factor to the culture media. So they say that it is not recommended. So media with growth factor are not recommended. You may use it, but it's not recommended. Clear cut. Laser hatching, not recommended. So don't do laser hatching as a routine for vacation. Not recommended at all. Carrying out PGT is not recommended for routine use. Not recommended. Very clear. Coming to NI, non-invasive PGT, currently not recommended for routine use. These things are very clear. Mitochondrial DNA load measurement, not recommended for routine clinical use. So you may do it, but for routine clinical use, they are not recommended. Until we have some indication, we can do it, but not as a routine. Time-lapse imaging, not recommended. It's not recommended. They have written that it's not only for routine use, it is not recommended at all. Time-lapse imaging, not recommended. Coming to the clinical part, we use a lot of PRP. Everyone is using PRP nowadays. So PRP can be given, it can be given intrauterine or it can be intra-ovarian. 2 ways we can give PRPs. Dr. Gupta, give me 2 minutes. Let me just close it, then I'll come back to you. So PRPs is not recommended, though we use it, but they have written PRP is not recommended. Intra-ovarian, not recommended. The beauty is that they have not written that it can be used not for routine use, but they have written not recommended. So that's a 4th classification. They don't say that we should be using PRP. This is as recent as 2023. Using a DOSIM protocol, large number of us are using DOSIMs. Currently not recommended, but later on we may be using it more, but currently not recommended. Coming to adjuncts during ovarian stimulation, and here I come. Look at all these things. Metformin, growth hormone, testosterone, DHEA, aspirin, endomethacin, sildenafil, before or during stimulation are not recommended. Clear cut, not recommended. So I'll take you back to what we learned before. These are the various criterias. So look at these definitions again. They have written very clearly that we have got 4 phrases. They are the 4 standard phrases. They are for recommendations, and we have got 42 recommendations. This is the phrase 1, phrase 2, phrase 3, and phrase 4. 4 means not recommended.
Everything is not recommended. They are
Yeah,
saying that.
they are there. It's in front of you only. Currently not recommended, but we can use it. It's not recommended for routine, but you may use it. And we need more evidence. When more evidence comes, we may be able to use it better. But they can optionally, it's an optional thing. Maybe considered, matlab, we can use that. Evidence is there, and you can, the recommendation can be adopted as a policy in most situations. So this is the first one. This is recommended. So out of 42, only 3 are, I could trace, are actual recommendations. Rest all are, few are can be considered, and majority are not recommended. So we use many things, so we can use, but you must know that what is optional. So this is optional. This is optional. So Moving ahead, these are the grades of recommendation. We got 4, 3, 2, and 1. So it is high, moderate, low, very low. So this is I spoke about hysteroscopy. Hysteroscopy is not recommended, currently not recommended for all. So it is optional. But it can be considered patients with RAF. So it is phrase 2. And this is phrase 3. ERA, not recommended, phrase 4. All the tests for immunology, they have very clearly written NK cells, uterine NK cells are 4, phrase 4, not recommended. And in case of cases where, and they've written about KIR and HLA, this is phase 3, phrase 3. All the treatments which we do, LIT, IVIG, PVMC, stem cells, they are not recommended, phrase 4, very clearly. Then as we move on, I've covered for oocyte activation also. It is recommended when we are having fertilization failure, not for all. Mitochondrial therapy, not recommended at all. This I've covered for you. In vitro activation, not recommended, not recommended. And IVM, currently not recommended for routine clinical use because it's only meant for PCO patients, and nowadays with the ATTACK protocol, it lost our charm. Coming to sperm DNA testing, which we do, is currently not recommended. It's a phrase 3. Sperm activation not to be done until we have got asthenospermia. So 2 of our recommendations are met here. Moving ahead, magnetic sperm separation, currently not recommended, but you may use it. And then sperm HBA binding and PIXI, currently not recommended. You may do it, it's an optional thing. Then coming to IMSI, not recommended. And microfluidics may be considered. So microfluidics is phrase 2, high recommendation. Growth factor in the culture media, not recommended, is 4, is phrase 4. Laser hatching is not recommended, phrase 4. Genetic testing, PGTA, are currently not recommended for clinical use, not recommended. They are phrase 3. And mitochondrial DNA, not recommended, phrase 3. Time-lapse imaging, not recommended. It's not. Phrase 4, not recommended at all. The clinical management, PRP, not recommended. You may do it. I also carry out, but not recommended. Till 23. Intravenous PRP, not recommended. We may write a paper, but not recommended as per ASHRAE. Diostim, currently not recommended for routine clinical use. And all the drugs like metformin, growth hormone are not recommended, clear cut. DHEA, endomethacin, growth hormone, metformin, testosterone, not recommended. I take a short halt here and listen to all of you. What do you all say about this? So Dr. Gupta, कुछ कहना चाह रहे थे आप?
सर आपने तो पूरा पोल खोल दिया मार्केट का।
नहीं, मैंने जो लिखा वही बता रहा हूँ मैं कोई पोल नहीं खोल रहा हूँ, तेरे आर्टिकल भी दूंगा मैं आपको।
मालूम है ना सर, इसलिए मैं बोल रहा हूँ आजकल मार्केट में जो बिजनेस चल रहा है फार्मास्यूटिकल्स, जो कंपनीज है, इसको ये टाइम लैप्स वगैरह का जो हवा बना के रखा है, क्लियर कट क्लियर कर दिया सर। You really have a courage to talk on this.
करेज क्या जो लिखा है, मैं तो गाइडलाइंस पढ़ रहा हूँ ना, करेक्ट मैं यूज करता हूँ। मैं यूज करता हूँ, मैं यूज करता हूँ, ऐसा नहीं मैं यूज नहीं करता हूँ, बट जो किताब में लिखा है वो तो वही तो पढ़ा रहा हूँ। आई एम गिविंग गाइडलाइंस, इट विल बी सेंट टू यू। मुझे एक फॉरेस्ट प्लॉट ही गलत मिला, वो भी बता दिया मैंने आपको, खुद पढ़िएगा फॉरेस्ट प्लॉट को। गो टू पेज नंबर 622 ऑफ गार्डनर। One of the forest plots have got a problem. So I'm not, I use it. I also use it, but not recommended है, बड़ा clear है वो।
Sir, how artificial activation of sperm done, sir, in a complete asthenospermia?
Yeah, they say that you can do it when there is complete asthenospermia. Then you can do it, but not for all.
Sir, how it is done, sir?
There's a pentoxifylline and theophylline available. You put around 3 to 4 microliters in one drop of 50 microliters of semen sample droplet, and they activate the sperms. We covered at great length in the last curtain raiser on culture medias. I covered all these things, but it is available commercially in the market. You can buy. The best company to buy these medias are Gynemed. Gynemed. So right spelling is Gynemed. I'm not for a company, but they make very good medias of these. They make fantastic medias of this nature. Some people use intravaginal. Dr. Gupta, may I proceed further? So
yes, sir. Yes. But I just want to talk. I just want to add on this thing. See,
बोलिए ना, please बोलिए.
dealing with infertility is very subjective. ये हर एक को पैरासिटामोल डोलो जैसा देते वैसा नहीं हो सकता. And also it depends upon the which race, which category and which people you are treating. जैसे राजस्थान में जो है वो महाराष्ट्र के फीमेल्स में नहीं हो, तो जो पंजाब में है वो आपको श्रीलंका या अपना साउथ के फीमेल्स में नहीं होगा. We have a very vast and a very different race we facing the treatment compared to the Europeans. यूरोपियन में इतने रेसेस नहीं है सर जितना हमारे इसमें कैटेगरी में इंडियंस में है. This has been very, we have to produce our own data and then we could talk something on this.
Agreed. I fully agree with you. We are, our women age early. We have lower AMH. I agree to all these things, but what we are not talking is, I'm not saying that, see, they have written not for routine application, but you may use it as optional. I also use it, but you must know, see, either we make our own guidelines or we follow the guidelines. So abhi jo hai, I'm telling you the data only. That's all I'm doing. I'm just showing you the data. I leave the choice to individuals, whatever you want to do. But let's look at the European data. It's a huge data. It's not a small data. Then they say additions to the transfer media. Some people add hyaluronan to the culture medias. Beautiful. Recommended. So use the medias with hyaluronan for embryo transfer. They have written this. और यहाँ पे क्या problem हो रहा है? Yogesh, multiple pregnancy. So this is one recommendation which is, I think I'll request you to talk about these things later. So, but hyaluronan is giving you multiple pregnancies. वो वरी है. So it's a good, so we should add hyaluronan as per the HRA guidelines. Scratching, currently not recommended. You may do it phase 3. Coming to flushing of uterus, some people put intrauterine HCG, some people put GCSF, some people do embryo culture supernatant. So they take the media, leftover media, put in the uterus. They're called this flushing of uterus, they call it. Not recommended, not recommended, not recommended. So GCSF, उड़ा दिया बिल्कुल. Recommended ही नहीं है. Endometrial exposure to seminal plasma. Not recommended. So what is endometrial exposure to seminal plasma? क्या होता है ये? What is this? So they take the semen sample and raw sample ko they put in the vagina and on the cervix. That's all they do. It is like using like a douching. Seminal plasma can activate some chemical factors and lead to better fertilization. So many people carry out endometrial exposure by douching. Not recommended. And all flushings with GCSF are not very clear, not recommended only. So whatever Dr. Gupta ने बोला है मैं बात मान रहा हूँ, but मैं सिर्फ आपको recommendation बता रहा हूँ. That's all I'm doing at this point of time. Using stem cell for poor ovarian response. So large number of us, we are using stem cell for this, and stem cell is again not recommended at all. The stem cells are not recommended, and see here, they are not recommended. So giving them in the uterine, intrauterine, or thin endometrium, they're not recommended. If you want to give, we can give, but they are not recommended. And not recommended means that we have to take as a part of research. And also, guys, understand that the populations may differ, but the outcome can't be so different that they make it not recommended. Just know that in case you want to do it, you do it, but it is Don't do it as a fashionable parade. Everyone starts doing these things. Don't do it. Steroids. Everyone asks, should I give steroids or not? Not recommended. Elective freeze-all. Currently not recommended. They are currently, so we can use it. But I still say, don't do much of FET. Try to do as much fresh as possible. Fresh gives you better outcome all the time. With FET, we got macrosomias and hypertension. ICSI for non-male infertility, not recommended. ICSI for all, not recommended. Do only for male factor, simple male factor. It's very clear, not recommended. It's a phrase 4. Antioxidants. ये बड़ा इंटरेस्टिंग है, बहुत इंटरेस्टिंग है. क्या लिखा है इसके अंदर? Anyone?
Not recommended ERT treatment.
Yes. Complementary alternative medicine, not recommended. All acupressures, punctures, whatever you do, not recommended. How are you all feeling? कैसा लग रहा है? Any comments from anyone?
Drained out.
Drained out?
फिर भी करेंगे.
नहीं सर, बहुत इजी हो गया.
Everything is not recommended.
हाँ, जो लिखा है वो बता रहा हूँ. I'll be sending you all the
पेशेंट्स एक दिन ये नहीं बोले कि हम ही recommended नहीं है, ये तो कुछ भी नहीं यूज करते.
कुछ यूज नहीं करते. तो ठीक है, जो लिखा है वो देखो.
बहुत लाइट फील हो रहा है.
लाइट हल्का सा फील हो रहा है कि सब बंद कर देते हैं लिखना. But ठीक है, it's interesting. Sometimes you need to do review of literature which is not. What is wrong with Shweta Rani? इसे क्या हो गया आज? इतनी उदास बैठी है आज. बोल नहीं रही तू आज बिल्कुल भी.
सर इमोशनल सेटिस्फैक्शन के लिए तो विल रेकमेंड सर.
हाँ, इमोशन के लिए कर सकते हो. Okay. Now coming to the very favorite friend of mine. I call it HFEA. HFEA, I love HFEA. They are very candid people. Treatment with add-ons. HFEA, क्या बोलते हैं? I hope you have heard about HFEA before. Human Fertilization and Embryology Authority.
Yes, sir.
They have taken all these things together. They have taken now ARCOS, which is part of BFS, British Infertility Counseling Association, ESHRE, fertility. So they take actually 9. They take 9 bodies always. They constitute HFEA and they publish a paper on 19th October 2023. इससे पहले पेपर था 2017. Dr. Shivani, are you there? Dr. Shivani? Dr. Shivani, in case she is there, I want to speak to her. So, madam, अगर आप पैटर्न इधर चेक करेंगे ना पुराना वाला on adjuvants के ऊपर, you'll find everything has been revised now.
Okay.
So everything has been revised. अगर आपके पास तो है ना, taken the package of quadrant laser. So you'll find it's a very different experience altogether.
Yes, sir.
So that was 2017, ma'am. This is now 23. They have got a Scientific and Clinical Advances Advisory Committee. They call it SCACC. ये उनके पास एक advisory committee है, and they work on this. And let's look at it. They had a concept called traffic light concept. Now this concept has gone. So they have used this. पहले इनका क्या था? पहले they were talking about red, green and amber. But now they are talking about this is getting stuck on Zoom. Okay. So now they're talking about these new symbols. Plus symbol means that high quality evidence. Plus green. Amber. पहले क्या था इनका? पहले था green light, red light, and amber light, like traffic light. But now green is green. Amber is not clear, doubtful. And red means stop. They have a traffic light concept. And question mark means they're confused. So amber के अंदर आप traffic light jump कर लोगे, you may not get caught. Red में light नहीं cross करनी है. and in green you can cross the light. In case you're confused, then you have to wait. No effect on the treatment outcome is 0. And here there are safety concerns. Red to use karna hi nahi hai. Red is not to be used. Green you may use. Amber plus minus. Question mark, we cannot rate the effectiveness. So we are confused. Insufficient data is there. Assisted hatching. We are confused. We don't know, but it should not be done. Actually, should not be done. Elective freeze-all cycles plus minus should not be done. We shouldn't do freeze cycles till the time the follicles are more than 10 to 12. Endometrium is poor quality or you want to do PGT. Otherwise, we should do for fresh only. ERA, red. ERA is red. Nahi karna. Endometrial scratching, as you can see here, is plus minus. Plus minus. Using hyaluron, using an embryo glue is plus minus. And what did Ashri talk about embryo glue? Any one of you?
It is to be used, recommended, sir.
Recommended. Out of 42, they have given only 3 recommendations. One is AOA in FERT failures. One is sperm activation for asthenospermia, complete asthenospermia. Then third was hyaluronate. But here they have said we are plus minus. Immunological testing, there it was not recommended. Here they are confused. Immunological test, IVIG, सब जो भी चीज हम करते रहते हैं, steroids, glucocorticoids are red. They are harmful. All the therapies which we do, internal lipids, lid therapies are not recommended. And here also they have written that it is red question mark. IMSI, confused, intrauterine culture confused. PIXI, I'm very fond of PIXI actually. 0 outcome. PGT, read this. PGT is red. It can be harmful. And time-lapse imaging, 0. So I just want to take you back. Plus meant there's no plus here. Plus any. HFEA with 9 bodies, they have not given any plus. They say it is good, but they have not given any plus to anyone. This is amber, not clear. Is it effective at not clear whether it works or not? So they have got conflicting data. Question mark means they cannot rate the effectiveness because the data ही नहीं है. अब data नहीं है तो उसको use कर लो आप. And create a data, they say. 0 means no effect. 0, no effect at all. Red means danger. They may reduce treatment effectiveness. Assisted hatching, question mark. They need probably more data. But I feel it is not the right thing. And as per the ASHRAE, they have written not recommended. We may use it in certain cases. Maybe we can use it for fertilization failures. We can use it for elderly women, but not as a routine. Elective freeze-all cycles, not recommended. Plus minus. Endometrial receptivity testing, not to be done. ERA nahi karna hai. Scratching, plus minus. So they're differing from there. But one thing is for sure that all these funny things we carry out, immunological testings, as per both the articles of 23 and 24, they are not recommended. PIXI not recommended. Time-lapse imaging not recommended. This is what they have written. And now as I finish my talk, leaving you all confused, I want you to think about whatever I've told you. And I think we take our own calls in life, whatever we want to do. Thoughts I leave for you is, what I understand is that should we add add-ons? I think we need more data. I use a lot of add-ons. I have got printed sheets of add-ons for my patients. I give them, everyone I give 4 or 5 add-ons. All my patients are 40 years and above. I do a lot of PIXI. lot of pixies I carry out. In every patient, I do microfluidics only. I don't do routine I left spawn preparation around year back. I don't do any centrifugation at all. And then I do pixie also for them, depending upon a sample. So I do. I use CoQs. I use arginine in nearly every patient. I use DHA in every patient. All my patients are 40 plus. I gave testosterone to all. So I'm using all these things. But I brought before you in this Katgara. I mean, you are the judges now. You judge what we are doing is right or wrong for yourself. So Nana, it's something like your Aam Papad. Very difficult to judge what to eat, what not to eat.
Yes.
It's like you can't have enough of Aam Papad which Nana and Kamal had got for us. It's so tempting that you want to eat everything and give everything. Something like that. Ram Lubhayal Aam Papad. So if any one of you is fond of Aam Papad, you can send a message to Nana. She'll parcel for you.
Yes, sure,
Okay.
sir.
It's like Aam Papad only. No, you can't say kya kare, kya chhode, kya na kare. Under Papad studies, majority of them. So we take the call. Patient deserves consistent evidence-based treatment, so you take your own call. But you should know what is right, what is wrong. Remember that additional cost is a big thing, and we should not be taxing patients with high pricing. This is it. This is it. Even HFEA and ASHRAE are at one point of time, they are differing at one point of time. But that's okay. But all of us, we give, we don't give. So calling 6 and 9. And then I think we are working on many assumptions, which can be wrong. I say that if you don't have a data, you may do it. You may use a drug, but at least in mind, have a fixation that it is not the right protocol. We are doing we are using it optionally. It's an option. Don't tell them that it is the right drug. Tell them it is not recommended. We are using it as an option. That's all that you should tell the patient. I always believe this sort of a management where we have more of green teas, tulsi leaves, very fond of grapes and blueberries. They are very good antioxidants and amlas. आजकल एक नया प्रॉब्लम शुरू हो गया हमारे देश के अंदर. Everyone is after avocados. मतलब कि folic acid नहीं खानी पर avocado खाना है सबको. They are asking whether how to make. Should I take mashed avocado or should I chop it? I don't know why every Indian in Gurugram is buying avocados. अमरूद नहीं खाएंगे, संतरा नहीं खाएंगे, avocado खाएंगे. Then they want to know recipes from me how to eat avocados. I say आम पापड़ खा लो नेना को चिट्ठी लिखकर, वो अच्छा रहेगा avocado से. आमले का आम पापड़ is very good. So this is the right thing to do. I think in case you look at when nothing is recommended, and these things are very, very good. Strawberries, amla shakes, broccoli is very good, whichever is available. I think that's the right drug management food management is very, very important. And as I move on to this, in case somebody is here in this group, I'll be very happy to say hello to them. Do what your heart says, but it should not apply it to all as a blanket. This is what I'm going to tell you here. Nice book. You can buy this book. It's got a lot of nice articles on these sort of subjects. It's a publication of IFS. Thank you so much. And without much of ado, I would like to invite my very dear friend and my backbone, Yogesh. Yogesh, are you there?
Yes, sir, I'm here. Am I audible and visible?
Yeah, Yogesh, I think आप बोलेंगे उसके बाद अगर हो तो Dr. Gupta can talk about her experience with stem cells. Because he does a lot of stem cells. So Yogesh, we can't see you. We can't see you, भाई. किधर है? कहाँ छुप गया तू?
I'm here, sir. I'm here.
Yeah.
I can see again.
Great.
Yes, sir. Can I?
Over to you, sir. Over to you. We want to listen to you. And then, Ambrosis, what do you feel about everything? as an
What I am
embryologist,
what I'm feeling, I'm not performing ICSI for all. It's from day one. From day one. If it is normal spermia, then it is only the conventional IVF, until unless I am having that background of previous failures or the low fertilization rate and all. What exactly happening at the level of me and you, sir? We all are running with the advertisement done by 80%, 90% success rate. But we are thinking just to improve the success rate. But actually, the guidelines and the ASHRAE, FEA, and all those are thinking about the imprinting. Imprinting is something that we should think about the progeny which we are getting in terms of the IVF pregnancies. So they are more curious and they are more conscious for the health of the baby. So they are simply not recommending all those nonsense that is actually not required. Number one.
Nonsense. You're calling it nonsense.
Secondly,
You're harsher than me.
Secondly, we should try to minimize the incurring cost of the IVF for the sake not to give anything additional which is not required. I came across one of the discharge paper of a lady that she told me that she took 25,000 rupees progesterone support. What was the need? 25,000 rupees is huge. And again, I came to know a few days back that few patients came and they were asking me about the laser assisted hatching, and they told me that they took 45,000 rupees for the sake of this assisted laser hatching unnecessarily. That is not recommended. So first, what we are going to do is we should think from the patient's point of view, number one. Secondly, we should publish our data genuinely, not just to give the pregnancy OD, ED and all those cases. We should be very clear with our genuine pregnancy outcome in all the groups, depending upon the age, the etiology and the confounding factors. Number four, the pregnancies which we are showing, that the source of the gametes and the embryos should be clear cut. It should be there. And when we are not thinking about the pregnancy rate, rather we should also think about the imprinting and the genetic well-being of the baby. Then we should be on an age where we can think, yes, what should be used and what should not be used. So it's all our gut feeling, our thinking and our practice as an embryology practice or the clinical ART practice. We should think from zero, and what unnecessarily is not required, we should just throw it out. Or if you are not in a position to throw it out, just to conduct some research on your own level by considering the race or the ethnicity or the geographical area or the environment or the whatever we are considering with the different environment of the geography. We should first conduct some research by our own, then we should conclude something. Just to run behind all those recommendations is also not good. I am not saying that you should stop everything, but before just to reach to any conclusive statement in your mind, just conduct your own research based on any molecules which you are using. This is from my side, sir.
You're so right, so candidly, but you called it nonsense. You very strong as always. So great.
Thank you so much to call me up for this meeting with all those geniuses. Thank you very much, sir.
You're the right person, yeah. You're the right person for this. I can see Rashmi. Hi, Rashmi. क्या हाल है? देखा नहीं बहुत दिन से. Anita, Nandita, Shikha. So I'm just saying hello to all of you whom I have missed. Hi, how are you? Archana.
Sir,
Yes. TikTok class monitor. Anupama, how are you, Anupama? Yes.
sir,
Any
how
questions?
endometrial receptivity test affect the treatment, sir?
Not recommended.
So
Not
how does it
recommended.
affect the treatment? It will reduce the treatment effectiveness.
No. In case you do it, hi Surjit, how are you? So see, what happens that in case we're having an implantation failure, no, or pregnancy failure, then we want to date the day of embryo transfer. We want to have an ideal embryo. We have to have an ideal endometrium. For that, we time the endometrial receptivity by doing a little biopsy in the previous cycle. So we know that after how many days we have a window of implantation. A lot of people are doing ERA, but ERA is no longer recommended. I'll be sending you the major article today, Ashray. Everything is covered here. So पढ़ लीजिएगा. I'll
Sir,
give it to you, Molly.
sir, I have one question. Why this error, sir? Because we use Applebaum classification, so many things for checking the endometrial receptivity. And error, will it hold the same what it hold in the previous cycle?
No, that's the reason ERA has been now rejected, no? Why is ERA being not recommended for this only? ERA has been
Sir, it's
is
not
not
just recommended. They have told it reduces the effectiveness of the treatment. How, like,
No,
when
that
it is
was
done?
in HFEA. But
Okay.
you look at the ASHRAE, they have not
Yesterday
recommended.
guidelines,
And ERA
they
is
have
no longer
just told
recommended.
they have not recommended. Yes.
No, ERA is not longer recommended.
Okay.
Dr.
Sir,
Gupta. Dr. Gupta के पास
Sir,
सुनिए,
what
he's a
about
very
culture?
detailed. Yeah, I'll just come to that. Let's listen to Dr. Gupta. He does a lot of stem cells. He's done trainings in stem cells. What do you feel about stem cells?
In my experience, I have till now I have done 30 cases.
Where is Chirayu? Chirayu. One second, Dr. Gupta. Where is Chirayu? I have not met Chirayu for a long time. He's just like, where are you? Where are you? Sorry, Dr. Gupta, कोई पुराना साथी मिल जाता है ना जो छुप के बैठा हुआ है. Hi, क्या हाल है? क्या हाल है? How are you? Good to see you. Just a way to just connect to the old friends. Hi, ठीक है? अच्छा, good. Good to see you, sir. वालो, बढ़िया रहो, खुश रहो.
Yeah, Mr.
हाँ जी. Dr. Gupta बताए. I'm sorry, I am sorry for this. आप
It's
बताएं.
okay, sir. Sir, my experience while doing the autologous stem cells, then I have categorized the people for where I have do these cases. And from these cases, since I have maternity hospital also, so what I have come to conclusion is that the autologous stem cells is not only going to increase the implantation rate, it also increases the placenta decidual reaction which we are lacking in luteal phase support जो हमको नहीं मिलता है फ्रोजन साइकिल में एफईडीज में जहां पे हमको बहुत सारा पीआईएच आईजीआर ये बहुत सारा प्रीएक्लेम्शियाज ये जो आईवीएफ के जो ड्रॉबैक्स है फ्रोजन साइकिल इक्सी वगैरह ये बहुत सारा चीज है ना सर इसमें वी एक्चुअली गेट अ neovascularization with this autologous stem cells. And it is very compromising, but it has to be modelized. Means कैसा थोड़ा सा इसको authenticity के लिए गवर्नमेंट से अगर आपको मिले परमिशन, if we have a grow just like a day 0 को हमने स्टार्टिंग में गिफ्ट कर रहे थे, तो गिफ्ट से हम अभी डे 1, डे 2, डे 3, डे 5 तक आ गए. उसी तरह से अगर हमको कल्चर ग्रो करने को मिला ऑटोलोगस स्टेम सेल, we can expandedly increase this thing and it can have a breakthrough for at least the patient who are ongoing pregnancies. और बहुत सारा अच्छा रिजल्ट है सर. Not only the patient having the healthy baby, but even IUGR has been dropped.
Okay. So that's very good. I think we're always learning from each other, and I think time will tell what is right or wrong, but I think good to get a good feedback from you. So I think anyone else would like to share anything before we say goodbye? आज क्विज नहीं है आज. मैं तो वैसे जीत जाती है तो मैंने कुछ रखा ही नहीं आज.
No chocolates.
है ना? No
Sir, you
chocolates.
always keep quiz on difficult topics, sir.
I know. आज क्विज नहीं है.
Sir, restricted food items during IVF treatment.
Nothing. I don't restrict anything. मैं एक ही चीज कहता हूँ कि बीड़ी नहीं पीनी, बीड़ी, हुक्का, सिगरेट, शीशा, 4 चीजें नहीं करना बस. I say that no, papaya is for pregnancy, not for raw papaya is for pregnancy, not for IVF treatment. And who eats raw papaya? Actually, कच्चा पपीता खाता कौन है? मुझे कब तक मिला नहीं खाने वाला. But we keep saying पपीता नहीं खाना. Who eats कच्चा पपीता? Good papaya has got papain. It is good for constipation. So it's not like that. But in case you want to really avoid, you should avoid Ajinomoto. That is Ajinomoto is a Chinese food that you can avoid. It's one thing which is not good. And smoking is always आजकल नया जमाना है शीशे का. The whole of Gurugram is high on shisha. It's a hookah. So smoking shisha, hookah should be avoided. Large amount of caffeine should be avoided. Caffeine is not a very good thing to take. Large amount of coffee should not be taken. I tell people not to take large amount of non-veg food. In fact, non-veg food should not be taken because spiritual reason, but large amount of non-veg got a high protein diet. Even that is not very good. I think that's all. Nothing much. Be happy.
Food with preservative should be avoided.
Preservatives. हाँ, बाहर का processed food मत खाओ. I only say just be happy. Have a lot of pizza, have a lot of Coke, just be happy. Happiness is more important. अगर आप गोलगप्पे खाओ, आम पापड़ खाओ, जो खाना खाओ,
No
just be
stress.
happy. No stress. Be happy. Don't kill yourself कि ये नहीं खाना, वो नहीं खाना. You know, when I was in the army, Vandana may not know, Vandana in our era, we used to say take only खिचड़ी. तो खिचड़ी खाना है और गरम खाना नहीं खाना. तो बेचारी वुमेन को हर रोज 2 टीके लगते थे 100 मिलीग्राम के, 50-50 मिलीग्राम के. उसके सबके बटक्स में लम्ब बन जाया करते थे. उनके हस्बैंड्स उनको हाथ में उठा के लेके जाते थे पॉट के ऊपर यूरिन पास करने के लिए. So much for the bed rest. And it's carried on for around 8-9 years with me in my practice. But that is through early 2000s. And then they all had दलिया और खिचड़ी, वो भी ठंडा, भी गर्म नहीं खाना, for nearly 30 days. और अगर पॉजिटिव आ गया तो 70 डेज हो जाता था उसका. So nowadays, आजकल life is fun. I say people have golgappa, chaat papdi, be happy. Happiness is the most important factor. You want to have a wine once in a while? No problem. But don't smoke. No alcohol. ये सब, everything. Smoking totally no. And alcohol you may take in little amount is absolutely okay. But कोई मना ही नहीं है. मैं तो मना नहीं करता हूँ. बाकी you can all share your things what you want to say. I don't say no. That's all from my side. And lovely seeing you people again. And we'll be meeting again after I think 15 days. We got a talk on I think RIF next. So we'll connect again. Thank you so much. God bless you and keep smiling. Thank you. Hi Manish, how are you? Where is
Thank you,
Manish?
sir. Thank you, sir. Thank you.
Hi. Professor Manish Ahuja, where are you? He's written some note. Hi, how are you? What do you say? Good. All well?
Sir.
Good.